the need is so overwhelming that there is a need for us to look for another neurosurgeon to go down to Mbarara. Neurosurgery is growing, not just in number of neurosurgeons, but in need as well. When you look at the road traffic accidents, 75% of all those people who are admitted in Mulago accident and emergency unit following a trauma have a neurosurgical problem. 75%. We are actually, there are more neurosurgical cases than there are any other discipline when it comes to trauma. When it comes to pediatrics, we told you that when we opened up a pediatric unit, it overwhelmed. Up to now, Cure Hospital is admitting sometimes in their chapel patients who are requiring neurosurgery. They had two operating theaters at the beginning. They have now expanded to 4. They had one neurosurgeon. They now have 4. And they are training another one. So you can see that the need is growing. The same is mirrored in Mbarara. So everywhere you can see that there is a cry for neurosurgery and the need for it to expand. The expansion has not just been in doing the basics. Neurosurgery has grown in complexity. When you look at the years when we began practicing and what we are doing now, you see that neurosurgery now handles almost everything except vascular surgery. And the need for us to take one of those training posts that we are offered to train a vascular neurosurgeon is very high because one of the growing numbers of conditions we are having now is stroke. And you not manage stroke without a vascular neurosurgeon. So we are putting our petition. We want to leapfrog anesthesia and say that really neurosurgery should be considered as number one when it comes to scholarships.
Good.
Thank you very much.
Thank you. Thank you. Thank you, Mr. Kiavile, for giving us that journey of neurosurgery. You know, when you hear neurosurgery, it is one of the complex surgeries which one has got to undergo, and usually when you tell somebody that he's going to be operated on the brain, it is always a challenge. But we want to really appreciate the system in which we have been able to develop. As you can see, neurosurgery has suffered so many years of just having one, and most being run by foreigners. And you reminded me of Professor Giovanni Kiriabwire, who was in that department for a very, very long time. You have mentioned the issue of brain drain, and that is still a big fear, because where there are limited people willing to specialize for a long time in that area, then we have that risk of brain drain. But members, just from Dr. Kiriabwire's description, let us just appreciate the two new centers of Mbarara and Chuambale. I think that is a good step in the right direction. We want to also appreciate Koseksa. I think because according to him, we couldn't be having these neurosurgeons here if they were not locally trained. And when he was describing, I started thinking, is the PSCZ that one of going? Is it, how do we ensure that it doesn't also create a brain drain? Because if someone has gone, so it's important that those who are going to be trained, there is a tight way in which it's done, so it doesn't create a brain drain. But we are very, very grateful to that. And finally, PSC has appealed for the training of vestibular neurosurgeons. How many do we have in the country?
Specialized, we have one.
one. So you can see 1 for 45 million Ugandans. And you have seen the frequency of stroke in our country. It is so high. Okay, good. Thank you. I have delivered your message directly, and so that keeps reducing the number for the 10 positions. Okay, I'll go on now to introduce my fifth panelist, Professor Moses Galkande, whom all of you know very well. Professor Moses heads the Department of Surgery in Makerere University, and he's also a chancellor of, I did not write the, Clark International University. The previous name was International Health Sciences University. And he's also the incoming president of Asou. I'm right, Dr. Frank? Good. Yeah. So, Professor, you are welcome to discuss for us the issue of surgical camps. I saw the chairman of the health committee, while he was presenting here, he seems to appreciate so much that those surgical camps. But you tell us how surgical camps have helped to increase the access to surgical care in this country in all the dimensions. Thank you.
Thank you very much, and good afternoon, ladies and gentlemen. Surgical camps, it simply means that a group of, in this situation, surgeons and the other support people they work with make a decision to go to a particular place, and they notify where they're going. And when they get to that place, they conduct operations, and in our context, for free. Typically, I think for nearly 25 years, I think this year will be the 25th year of doing surgical camps. They typically stay there for a week. But there's prior warning. So prior warning means that the communities are mobilized, the people go and register at particular centers where the surgery is going to take place, and the surgery is conducted for a week for free. The records we have, the first was documented in Professor Akane documented the first one could have happened in 2000, so we're going to make 25 years. And that particular one was in Lango sub-region, and they managed to see about 500 patients and operated on 272. Fast forward, last year, about 2,000 plus showed up, and about 1,400 were operated in 1 week. This year, September, we're going to go to the Ankole sub-region, cover about 12 districts. We anticipate to have 5,000 people coming. And this 5,000 will have a surgical consult at least. We anticipate we may operate 2,500. There is a caveat to that, which I'll mention in a bit. But we anticipate to do 2,500 operations in 1 week. And this is for free. Now, even if it's for free to the patient, the resources have to come from somewhere. So the surgeons, the anesthesiologists, the nurses, the lab people, the imaging people donate their time and skills for free. They don't charge any money. And then for the rest of the things, because you need sutures, you need intravenous fluids, you need pain medicines, you need all those things. So those ones, we normally run around like headless chickens to the different people, different organizations. Of course, we collaborate a lot with the Ministry of Health and then we get those resources, and then be able to conduct those procedures. Now, what has happened in the past was that when the announcements are made in the locality where the camp is going to happen, patients come. So by the time you get there, you don't know who's going to come. So everyone comes. It's kind of opportunistic. We are going to change that a little bit. We shall allow for whoever one needs to come, but we're also going to now be intentional about the different subspecialties. So we're going to mention, for example, in the Akole sub-region, we are coming, and anyone with breast issues, please go to Center A. Anyone with whatever issues, go to Center C. So we're going to be intentional about dealing with the subspecialties. And that has very many advantages, like you can imagine. So that's the story of surgical camps. So it's about increasing access to surgical care. Surgical care is one of the most constrained disciplines for people to access care for many reasons. And some of the reasons I'm sure you've heard as people have articulated the different challenges in the different subspecialties. So when you go nearer to where the people are, you're going to improve the possibility that they're going to show up in that place, and then their surgery is going to be conducted for free. Yeah, and so this is normally teamwork. Like I mentioned, the different, you can't do it without nurses, you can't do it without anesthesia people. So it's teamwork to pull this off. And we're going to keep doing it. We're excited about what Honorable Bayum has said, that they are mobilizing some money, get it in a budget somewhere so that it's predictable, in a sense. Now, how much does it cost us to do these procedures? When we put these monies together, it costs us about an equivalent of $100 to do one procedure. If you even it out, $100. But that's at the direct cost without counting the time donation and so on and so forth. Perhaps if you did that, it may be 3 times that. We think it may be 3 times that if you costed everything. So if we go to the Akole sub-region and see 5,000 people, the association would have donated how many dollars are those?
5,000.
If $300 is 1 million, about, so times 5,000. So that is going to be the worth of the work that's going to be put in that place. And what we need is about, in terms of real cash, we'll need maybe about 30% of that, 25–30% of that, for us to pull off this camp. So we're excited about this year, what we're going to do. Grateful to everyone who participates, and also those brains that initiated this idea 25 years ago, for the surgeons to give back to the community, for the surgeons to improve access to care, surgical care in this country. Thank you.
Good. Thank you so much. Let's appreciate Prof. Members, significantly, surgical camps have become very, very popular in the country. And whenever this surgeon is announced, it is like people were waiting which day, and they keep flocking. And we appreciate that you are having a balanced approach, especially the regionalization. This year you are in this region, another year in another region. We appreciate that. But significantly, the issue of access to a free service, accessing a surgeon at free, maybe a highly specialized operation, maybe a baby has been suffering for some time with a condition, and you finally have it delivered for free. I think that we appreciate that for our surgeons giving back to the community. and he has given us that announcement from Mbarara. I hope people are not going to keep shifting to go to Mbarara. So now, let's move on to the our last presenter, who is Flavia. Fatia. I'm moving very fast. Don't worry, we are about to go for lunch. Fatia, who is going to give us the patient side of perception to what the surgeons do. And Fatia is the executive director of human rights. I think she will add on human rights something. It's a group where she is an executive director. Thank you, and Fatia, you are welcome. Good.
Thank you so much, and allow me to observe the protocol that has been set before. Because I can see time is not on our side, and thank you for giving me this space. I am Fatia Chiange. I'm the executive director of an organization called Center for Health, Human Rights and Development, CEHAD. We advance the right to health for all people, and more so the most vulnerable people in our country. Of course, we are very passionate about the right to health, which comes with the principles of availability of services. I've had colleagues here speak about availability. It comes with the issues of accessibility, affordability, acceptability, which is very important, and also the quality. I'm one of those who has benefited from successful surgery in this country. And I clearly know that this country has the best healthcare workers, and specifically the surgeons, because also I've traveled a bit of Africa, a bit of the world, and every corner you go to in this world, you'll find a surgeon or a healthcare worker from this country. That is reassuring that our healthcare workers are actually the best, among the best in the world. Allow me to appreciate Dr. Falal, because I said that I've benefited from successful surgery, and because of you, the surgeons, we are living. So I want to thank you for saving lives in the country, and I want to also appreciate the Ministry of Health and the government of Uganda for investing in this very important field that is to do with saving lives. Now, I've been asked to speak from a patient's perspective. And when I was asked to speak about this, I actually wondered whether the person who recommended me to speak knew that I'm actually currently taking care of a patient who was operated less than 2 months ago in one of our hospitals here in Kampala. Very close relative to me. And they were operated while I was away. I'd asked them to wait for me, but they didn't wait. So they went in to be operated in one of our hospitals here. And when I came back and got to the hospital, it was just a day after their surgery. Now, I found this patient in a very bad situation. The first thing that came to my mind was the respect and dignity of this patient, who was my close relative. Just looking at him and looking at his surrounding, the issues of dignity were completely taken away. You could see a patient whose dignity is completely taken away. And I know him as somebody who is respected, the other side, as somebody that I know. So, I want to say that we do have great surgeons, great professionals, but I think we also have some areas that would require improvement, especially with the actions of the professional associations that are here. Now, this gentleman was experiencing issues. He was in a lot of pain. The stomach was swelling. He had a catheter and other issues, but the things were going outside the catheter. So he had actually asked everybody to come and help. but the people who were there were not able to help. So he actually picked his phone and called the surgeon. And the surgeon shouted at him. He said to him, "Who even gave you my number? Never call me again." And I just came right on time. And he told me, if you had not come, I was actually ready to go. I had asked for my kanzu here. I wanted to put my kanzu and leave this hospital. Even if they shot me because of going away, I was going to leave. And he was so much distressed. And I asked him, "Can you also just give me the number?" And I tried to speak to this person. He gave me the number. I called the surgeon. And I said, "Your patient here in this hospital wants your help." And he said, "Who told you he has not?" He told me, "Who told you he has not been helped?" I said to him, "I'm here with him. I can see he has told me he needs your help." He hung up. This surgeon hung up. The man had actually cried. And the man told me, "You see, I told you." The man shouted at me. So I now used my capacity as somebody working in health rights to speak to the healthcare workers on that ward and said, "Do you know that patients have a right to many things, the right to dignity, also to decent care? And do you know that if he gets a problem, you're going to be accountable? Also, your hospital will be accountable." I sent the same message to this surgeon. And after that, these people, after even them knowing where I work, they all started running around to come and support. 10 people, one in a row, coming, this one bringing this and that, to sort out this patient. But eventually, much later, this surgeon came, and I looked at him. He didn't realize it was me. I talked to him that it's actually myself who was calling you. And he was a young, proud surgeon, very, very proud. Very proud. Very proud. So eventually he came to see the patient. And the patient actually cried. And I was there observing. So why am I sharing this? I'm sharing this because we are doing a good job, but there are those that probably have not been nurtured and mentored to actually look at the person they are operating beyond the disease. People that have emotions, people that actually can suffer. So I think, and I wanted to link that to the fact that in Uganda we have patient rights and responsibilities, Patient Rights and Responsibilities Charter of 2019. The charter is for Ministry of Health. It is available online. I really want to challenge ourselves to see that all our healthcare workers, all our surgeons, especially the young ones, are well-oriented and nurtured in terms of patient rights. Patients have, this charter enables the surgeon and the patient to have a good relationship. Now, the relationship between the healthcare worker and the patient determines the outcome. It can determine the outcome of the intervention. But above all, it can determine how this patient and family will react to the outcome of the surgery. We've seen situations where perhaps a relative dies or gets a problem after surgery, and the family will say the surgeon did their best. Why? Because the prior relationship was good. But we have also seen where somebody passes away, and all that the family had to say is, we knew that he would not survive. Now, I mentioned to this surgeon that this man is likely to get an infection. And indeed, when they were to discharge the patient, he actually had an infection. But that aside, the patient was discharged. I want to tell you, he's a patient who cannot afford health costs, and actually I'm the one taking care of that. But since he was discharged, it's about 2 months ago now, but even today, the man is in a lot of pain. It was a surgery to do with prostate cancer, which probably should be successful, but the man has had a lot of issues. We tried to seek for medical intervention somewhere else. They're also wondering what has happened. One of the physicians told us now we might have to go for an MRI because it looks like perhaps during the surgery something went wrong. You see, so we have had to go through a lot of issues. The patient is going through a lot of pain. He can't walk for even 10 minutes consistently, and we do not know exactly what to do. Now, I want to conclude with some recommendations based on that. I think it's important to educate patients and to educate us, the public, on the rights of patients, because this person had become too vulnerable to even understand that it is his right to have decent and professional care in a hospital. He felt helpless, and the only thing he could do was to think of running out of the hospital. But he had a catheter and other gadgets he could not, but he was set in his mind to run out. Also, I think it's important to adopt a holistic approach of management, to think beyond the disease, and that this disease is actually on a human being that has so many facets, including the social issues, the psychological issues, the spiritual, and so on. So I think it's important to use a holistic approach. I think it's important for the surgeons to give attention to post-surgical care, the follow-up, the referrals. The surgeon does not know that the patient 2 months later is actually struggling, and that we are also paying a lot of costs, and we have not even found a solution yet. So I think it's important to pay more attention to post-surgical care for our patients in the country. And I think I see from the Patients' Rights Charter that in any healthcare facility, there is need to have a designated person who is taking care of observance of human rights, and who can actually address issues of the rights of patients. And for me, that's my recommendation, that it's important, at least let facilities put in place a mechanism and an accountability platform through which the public and the patients can actually submit if they have any concerns. And I think, having seen this one as a young specialist, very proud, I think I would like to recommend more supervision, the nurturing and mentoring of the young surgeons to respect patients' rights. I think the generations before these ones today are actually getting it right. But the young ones, I'm sorry, I'm generalizing, definitely not everyone, but I think there is need to pay more attention to that mentorship. And I think, generally speaking, I would like to recommend, finally, I'm finalizing, in maternal health in Uganda here, the Ministry of Health has piloted a best practice. And that best practice is to do with maternal deaths. They are doing weekly surveillance for maternal deaths, and they have done maternal death audits, and that is helping to improve the situation overall. I think you could even see how our maternal mortality rates have gone down. It's also a recommendation that I want to leave with us here. Can we think of some form of surveillance, regular surveillance, to ensure who has died after surgery, what are the reasons behind this, is it skills, is it attitude, what is it, so that we are able to encounter some of these issues that patients are facing. Thank you so much.
Thank you so much, Fatia. Let's give her another hand. Fatia has shared a very distressing story, but when she describes, probably all of us in medical practice, some of these you may not be hearing or knowing it for the first time, but these are silent, some of the silent stories down there. But we want to thank you for sharing, and you have shared with a big team of surgeons here, and your recommendations will be taken into consideration. And my appeal from this is the training needs to focus on that section which is ignored. We are imparting a lot of knowledge, skills, but that care for people, we seem to have left it aside. The heart, the feeling for another person has been as testified there, and it is something which we need to look into. I want to thank the team. Maybe Just one second, you just say one thing which we can leave with the audience here, and I will start from Professor Moses as we come straight here.
Thank you very much, everyone, for your patience. Two things. One is to appreciate everyone, every institution, every individual that has supported the surgical camps in the past, and also to say continue the support. We'll carry on, and when we knock at your doors, please don't please support, and we also appreciate the Parliamentary Committee on Health Issues for negotiating that support that they have, and we're looking forward to receiving it and carrying on with this work. Thank you.
They have come.
Thank you very much. So just two things. So we anticipate that by next year we shall have started training anesthesiologists under the College of Anesthesia for Eastern, Central and Southern Africa, CANEXA. We are in the process of accrediting 3 centers to do that. The other thing is that please pass by our booth, get to know what the anesthesiologist does so that you spread the word that surgery can be safer and you'll be less worried about waking up. Thank you.
Thank you. A hand clap, I think you are getting tired, but just those are the last moments. Dr. Sekaway.
Thank you, moderator. Maybe I would like what I want to say that following what Dr. Chiwanuka was mentioning about college, the other training of anesthesiologists, pediatric surgery we have started already. Okay, pediatric anesthesia, we have already gotten pediatric anesthesia trained fellows under CANEXA, and that one has changed the landscape of pediatric surgery because, as I said, surgeons don't work in isolation, they work with anesthesiologists. And for example, in Mulago, pediatric surgery has the biggest output when you analyze what is coming out, because a week we operate like 20 or 30 patients. And thanks to having pediatric anesthesia fellows who work closely with the pediatric anesthesia training, the other pediatric surgeons who are training, so the output has markedly improved. So the way to go is to start fellowship training programs. They will help in improving outcomes and even outputs. Thank you.
Thank you so much. Hand clap for Pro. Good. Dr. Luisa?
Yes, thank you. I want to say this. I see and I know I've been here in this country for 3 years now, and I see that this country is doing very well. I'm very proud to be part of the health system of this country because there is a very big willing to improve the health system. And what I see also in this meeting is that there is a lot of work behind all of you. What I want to stress is the necessity to cooperate between hospitals, between facilities. I think that training is the focus, but also referral of the patients, in my case for children, between specialized staff and specialized hospitals, because we can strengthen the good outcome of the patients globally and the children in particular. So I think and I hope that we can improve the cooperation between all the facilities involved in the healthcare system. Thank you.
Good. Thank you, Angela.
Yes. As we speak today, in Uganda, we have 1 neurosurgeon to more than 2 million people. This contrasts with what the WHO recommends, where they say we should have 1 neurosurgeon for every 100,000 people. The job ahead of us is enormous. Without training locally, without emphasizing specialization within the field of neurosurgery, we are going to find ourselves in a crisis. We want to thank the Ministry of Health for every support that we have been given up to this date. We want to thank all the training institutions that have been working with us to try and address this issue. And for us, we see that the future is about working hard. It's about putting in effort to make a difference for this country. Please, when you get a moment, pass through the booths. We have got 2 booths. Come and see what we are doing. And when we call on you to partner with us, we are hoping that you shall lend a hand to make a difference in this field. Thank you very much.
Thank you so much. Ms. Fatia.
Thank you so much. I want to appreciate and thank our government, the Ministry of Health, the members of parliament, and other arms of government for the visible advancements we are seeing in the field of surgery in our country. And I want to call upon the government still to invest much more. As we can hear, the gaps are huge. And I think we can only invest more for us to be even more proud than we are right now. I also want to call upon the professionals, the surgeons, and the professional associations and councils in charge to ensure that people receive the respect and dignity that we ourselves would wish to get when we step into that side of being patients. But I thank you for the good job that you're doing and for the selfless efforts you're putting in to save lives.
Fatia? Yes, a hand clap for that. Members, we have come to the end, and as you establish culture in the morning, I think PS, DJ, director, and the president said that photo with these panelists, very key. As that flows, I just want to guide on the lunch program as provided here, that members, you are going to be picked from, they will follow table by table. That you should not, it is a caution here that you should not move without being requested to move. Thank you. I invite us for that photo moment. Thank you. Thank you, team, all of you, for being a very good audience. Thank you.
Ladies and gentlemen, a big clap for our moderator. Now, our guest of honor is arriving in the next 10 minutes or 15 minutes, so we need to handle the next sessions as fast as possible. May I request that those who are guiding the lunch should take over immediately and start guiding the people immediately for lunch. Yes. Yes. It has been agreed that we have lunch because people are hungry as the guest of honors arrive. So allow people to take lunch. Don't mind about the protocol. Allow people to take lunch now because the guest of honor is arriving any time from now.
Thank you very much. Those from the high table, you just proceed straight to having lunch, being guided by Madame Lydian. The rest of us, we know our senior colleagues, you are going to also be guided to join the line after. The rest of us, we have coupons that have been given to us. Please, if you haven't got your coupon, go to the registration desk so that they sort you very well. Please, let's follow that so that everyone can be comfortable. I thank you.
I'm Dr. Koyamba Vianney. I'm a medical officer special grade in Mulago Hospital, National Referral Hospital. Specifically, I work in the Department of GIT surgery, and I work as a hepatobiliary and pancreatic surgeon, and also as a laparoscopic surgeon. But today I'm talking about the endoscopy unit because I also work in the endoscopy unit of Mulago Hospital, where we do endoscopies. And the endoscopy unit of Mulago has been there for more than 20 years, and over time it has worked on so many patients. So in the endoscopy, we do 3 major things. One, we diagnose disease of the stomach and esophagus. We put a camera through here and we look into the esophagus. We also use endoscopy to diagnose the disease of the colon, and we pass the camera through the anal area and we look at the colon. In so doing, we can know what is really paining these people. Many people come and say we have ulcers, the ulcers are not healing, the ulcers are due to H. pylori, yet they are not due to H. pylori. Sometimes that pain you feel in the stomach may be another issue. It may be a cancer, it may be candida in the esophagus, so many things. So the endoscopy helps us to know exactly what is causing this pain in the stomach. We put the person to sleep a bit, not so much, so that he doesn't get a problem, discomfort when your camera is being passed. And then we take our time. In the upper, we can take even almost 5 minutes to look carefully up to down in the stomach. And also in the colon, we take around 30 minutes to look carefully what is causing this problem. And once we find the problem, we can now know what to do, what to treat. So many people are treating things they don't know because they are not doing these endoscopies or colonoscopy. Some of the diseases which we find, we can treat on endoscopy itself. And that's what we call therapeutic endoscopy. For example, some people may have ulcers which are bleeding ulcers. And those bleeding ulcers need us to clip them or to seal them so that they stop bleeding. And that one we can only do it through endoscopy. And the endoscopy, we don't cut anywhere. So there are diseases we treat with endoscopy, and someone may even think we did nothing, but when we have done so much for them. And also when we find that most probably the problem is maybe like cancer, we take off some samples to confirm, so that the person who's going to operate the cancer knows what to do. So right now, as we are standing in our endoscopy unit. It is a big unit. We do more than 10 endoscopies per day. That means 5 days a week. Anyone can come in and book an endoscopy, and we work on it. So Mulago, we are really blessed to have this service. Yeah, so, and we have so many people doing it. No, I'm not the only one. We have surgeons, physicians. It's a team of like 6 to 7 specialists, all of them knowing how to do endoscopy and colonoscopy. So that at any particular part of the week, endoscopy is being what? Offered. So as an Asou member, Asou is the Association of Surgeons of Uganda, and also a Mulago employee, it's very good to show what surgeons can do and why these surgical services are important, and people shouldn't fear them because they help them.
Hello everyone, I'm Dr. Michael Kello, hepatobiliary surgeon and the president of the Society of Uganda Gastrointestinal and Endoscopic Surgeons. You're all welcome to the Dr. Rita Mbosa Transplant Center, which was set up following the transplant law guidelines. We have our main theater adjacent to the ICU, and this theater was commissioned by the Director General of Health Services in August last year. And we are awaiting the formation of the Transplant Council so that we get accredited. For the meantime, we are doing all the complex surgeries here, advanced laparoscopic surgeries, liver resections, Whipple's resections. And following a paper we published just this year in Feb, We started doing these complex liver surgeries in 2018 after our training in India. And from that time, our outcomes are improving. And patients who that needed to travel out of the country can now be helped within the country because of the expertise that they have now. And as we await for approval, we look forward to starting transplant surgeries.
My name is Dr. Chiemba Henry. I am a general surgeon at Rubaga Hospital. Briefly about the Dr. Rita Musa Transplant Center, named after Dr. Rita Musa, one of the longest serving medical directors of Rubaga Hospital. The transplant center is divided into 3 subunits. We have the operating theater, the intensive care unit, ICU, and then the CSSD, which is the central sterilizing and supplies department. We have a subdivision of the operating theater, whereby we have a preparation room where the patient is received from the ward into this room. The preparation room serves as an initial point whereby the patient is assessed by the anesthesiologist just before the procedure. Any medication needed to be given before the procedure or any other intervention such as central lines are placed within this preparation room. From this room, we go on to the operating theaters, which are 2. We have 2 operating rooms and a scrubbing area. The 2 operating rooms, when the transplant center kicks off and we're allowed to do transplants, one will serve as the donor room and then the other one will serve as the recipient room. The 2 rooms for this purpose have an adjoining door that connects the 2 rooms for ease of movement between the donor room and the recipient room. Currently, the unit is working on complex GI surgeries as well as hepatobiliary surgeries. Both open and also laparoscopic surgeries are taking place. After the operation has taken place, the patient is then moved to the post-anesthesia care unit, where the patient is monitored post-operatively before they are transferred back to the ward. And if need be, we also have a high dependence unit where the patient can be placed for close monitoring by the anesthesia team. In the event that the patient needs an ICU admission, the ICU is within close proximity to the operating theater. The patient is then transferred from the OR straight into the intensive care unit for high-end postoperative care. In the event that the surgeons are taking a break, we have a staff lounge, whereby still we have a screen that allows the surgeons or the staff within theater to continue following the cases that are happening, as one of the operating rooms has a camera that can screen what is happening inside the operating room to the staff lounge. Thank you.
Hello. For the sake of this, I'll remove my mask because, of course, in theater we should be in masks. My name is Dr. Gabriel Okumu, head of surgery department at Nakasero Hospital. I've been here from 2016, so that is about 8 years. Yeah, Nakasero Hospital has been in existence from 2009. So ever since we started, it has been offering surgical services. And over the years, we've been improving the services that we offer in Nakasero Hospital. So currently, our surgery department has almost every surgical procedure is done here. We do orthopedics, we do neurosurgery, we do abdominal surgery, definitely. We do ENT surgery, we do cardiothoracic chest surgery, we do plastic surgery, and also the other side of the obstetrics, the women's side, we do obstetrics and all kinds of gynecological surgeries here. Currently, we've been offering services, and one of the things that are relatively new here is laparoscopic surgery, or what we call minimal invasive surgery. And in that, the newest service we have currently is we're trying to improve on our, what I may call bariatric surgery, or weight loss surgery. The services for weight loss, the demand is increasing in Uganda, especially Kampala. So we have a good number of clients who come for weight loss surgery. So now we do weight loss surgeries here. We offer balloons for weight loss that make the stomach size, the stomach volume smaller when somebody wants to cut weight. We also have gastric plication surgery. We make the stomach smaller by plicating it, putting stitches. Then we also have the sleeve surgery, where we cut the stomach into half and then make it a sleeve, and then the person's stomach volume becomes smaller. We also offer bypass surgeries for weight loss. And we have a good number of clients who have benefited from these services. What we intend to start in the nearest future, which we're actually starting most likely this month, is want to start what we call ERCP, that is endoscopic retrograde cholangiopancreatography. That's a surgery where somebody has the stones in the gallbladder, and the person gets a complication where the stone is going to the tubes, and then there's a special way to remove those tubes. We get quite a number of cases with this, and the services are there in Kampala, but not widespread. So as a hospital, we think this one of the services we're going to start soon. So soon we're starting. We've already done the training. I did training. Another colleague of mine, Dr. Koyama, did training. Our nurses have trained. So the team is ready and just trying to organize ourselves to start soon. Also among the new services we have as anesthesia side, also improving. But generally surgery, I think we are trying to improve on what you already have. We're trying to expand on laparoscopic surgeries. So right now we're trying to offer almost every kind of laparoscopic surgery for the abdomen. And I thank God that I think as I see as the years go by, most of the doctors now are adopting laparoscopic surgery or minimal access surgery. So we are doing less cutting, especially for all cases that can be done without cutting. We're trying to make sure we can do them without cutting, and that's what we're trying to improve here. And one of our goals as Nakasero Hospital is to be a center of excellence for minimal access surgery. That's why the orthopedics are doing the arthroscopies, the ENTs are now doing the face surgery, and they're also doing brainstem tumors, cancers below the brain without cutting. They just pass in the nose and do them. And also the gynecological team is also doing well, because of late we was doing the hysterectomies, removing the uterus, removing masses or swellings in the uterus, and also all surgeries basically. Another area where we're trying to expound is in hemorrhoid surgery, that is swellings in the anus that cause people to bleed and get pain and have difficulty passing stool. We now offer laser surgery. Well, I've done that for some time, but we're trying to improve on laser surgery for hemorrhoids, which is something good. On the side of urology, we're also trying to improve on our surgery, which is minimal access, so we do endoscopic surgeries, especially stones in the kidney. We see quite a number of clients, especially Caucasians, the Indian race, also is common among the Ethiopians, the Eritreans, who come with stones in the kidneys. So our team is now trying to remove the stones from the kidney up there without cutting patients. So we thank the team, the management, the hospital, the board for all the support. Yes, part of the services we offer here is that, of course, we have to work with several departments. Like I've talked about the weight loss surgeries. You cannot do weight loss surgery as a surgeon alone. When you're doing weight loss surgery, you have to have the nutritionist on board. You must have the physician on board, because a good number of them have other conditions. Somebody comes with big size, they're obese, but they also have diabetes, they have hypertension, their joints are weak, and many times they have other conditions, what they call the syndrome X. So we work in conjunction with other team members. Nutritionists has to be on board, even psychiatrists, because a good number of them are depressed. They really feel, in fact, many people become big because of depression. They eating their way out of trouble. So the psychiatrists also play a role in a good number of the clients. Then also in collaboration, work very closely in hand with the anesthesia team, because surgery you cannot do without anesthesia. You can't cut when somebody's in pain. So we work with a team of anesthesia, they make the patient sleep, make the patients comfortable, then we do a surgery. Then also work together to offer pain after surgery. Surgical care after, we always do it as a team. One of the areas that are trying to improve so much in Nakasero is what we call the ambulatory surgical services. That means the patient comes in the morning, you do a surgery, and they go home in the evening. It's very good. Why? The patient will go back home. That means the relatives don't have to come to hospital. The patient can stay home. Most of them are mothers, fathers, so they don't have to stay with their kids. They can go back to stay with their kids at home. Then even for the hospital, the cost is less to go back home. So you can even resume more quickly. Trying to improve that area of ambulatory surgical services. So the nursing team, of course, plays a very big role in that. If you operate somebody today and they go home tomorrow, you have to find out how they are. So there has to be somebody to call them and find out, how are you? How have you done? How was the night? Was the pain bad? Is there any bleeding? How is the wound? How is the dressing? If need be, we send teams to go home and look at them and see what is happening. So we work hand in hand with many departments. Also within the hospital, in the inpatient department, several times you have to work with a physician. The physician is treating a patient. The patient reaches a point where they are vomiting so much, they are not passing stool well, so we have to go and see as surgeons also. So we work interdependently. We need each other in the hospital, all departments together. Pediatrics, there are some pediatric cases they call us to see. Gynecologists, at times they're doing surgeries, they get stuck, the intestine is stuck on the uterus, they call us, we go and work with them. Even as sometimes we work and find that the problem we thought was appendix actually is an ovarian problem. So you have to call them in and work together with the gynecological team. So there's so much interdependency in the work we do in the hospital, which is something good. Another side we don't mention, sometimes the spiritual side as well, also need counseling. Many patients need counseling. So we have psychologists who do that very well and work hand in hand with them.
Pre-operatively, we meet our clients through calls. We let them know that we are their service providers and we are here to give them safe surgeries and we remind them about the surgery time. While they come in, pre-operative care begins with the nurse by receiving the patient through the main reception. She reassures the patient, introduces herself to the patient, and affirms to them that they are the right nurses or the right team in theatre to take care of them, and they calm their anxieties right away from the main reception to the reception of theatre. As they come in, that is all pre-op. However, this also goes with making sure they give them the right attires, they make sure their ornaments like rings, earrings, watches, they are valuables mainly that can be kept safe, but also during surgery that they are not electrified. That is all pre-op. Then intra-op, they support the patients through signing out and time out. What do I mean by this? We affirm that this is the right patient by the nurse who is the circulating nurse, makes sure she introduces the client to us, goes ahead to tell us what we're supposed to do, confirms the surgery, confirms the team by making sure we know who are the team members ready for this surgery by mentioning their names, what are their roles, and then after that, we affirm the time of surgery, and inside still the theatre, we make sure that there is a board. This board affirms to us whatever we've said in the operation room, that is the right information, so that patient safety is kept as a key standard operating procedure.
So one of the new things we're having is that we are having an expansion, and currently Nakasero has 2 operating theatres which can do all surgeries. One has a C-arm, one has no C-arm. And also we have another, what you call a minor theatre, where we do endoscopies and other simple things. But very soon, actually the new building is up, and we have begun the occupancy. The outpatient department is now functional, the pharmacy is functional. So in the new building, we're going to have 2 more theatres. So all in all, we hope by maybe in a month's time we shall be having 4 operation theatres which are all functional, which can all do any surgery possible. But of course, we'll kind of make them specific. Some to be for the orthopedic, maybe neuro, cardiothoracic, then others to be ECs and other things. But we shall have 4 theatres. That will improve our services definitely, because we shall have more space for operation and space for recovery. With the new theatres will be a bigger recovery area, a bigger waiting area, right now we are squashed in space, so our patients really, we apologize to them because they struggle when they come here, the space is smaller, but with time, we're going to have an expansion, have a bigger theatre, better services. We shall have, of course, new things with the new theatre, new operating bed, new lights, new anesthesia machines. I believe the team will get bigger, definitely. So I believe the services are going to get better for the patients.
I would like to take this opportunity to welcome you to the Directorate of Surgery of St. Francis Hospital in Zambia. The Directorate of Surgery of St. Francis Hospital in Zambia runs different specialty surgical practices, ranging from practices that are open and those that are minimally invasive surgery. So we have a broad array of surgeries, ranging from orthopedics, ENT and oromaxillofacial, urology, gastrointestinal surgery, pediatric surgery, plastics and reconstructive surgery,
neurosurgery, breast and endocrine surgery, and any other possible surgery subspecialties. We provide these services under both general and private surgical services. We are proud to do this in association with different adjuncts. The desired surgical outcomes, especially in diagnostics, we benefit from a SANAS accredited laboratory. We have radiology, CT scan, MRI, mammography. We have endoscopy, and we are proud also to say that we have a very well-equipped skills lab from which our trainees can learn different skills in surgery. We also have support services from oncology and palliative care, as well as intensive care. We are proud also to associate and work with a postgraduate training school, Mother Kevin Postgraduate School, and we have trainees from Mother Kevin Postgraduate School, as well as trainees from the College of Surgeons of East, Central and Southern Africa, COSEXA. On behalf of the Department of Surgery of St. Francis Hospital in Zambia, we are proud to associate with Asou surgical landscape, and we would like to take this opportunity to invite the general population to come, benefit and explore the wide range of surgical services that we have at this hospital.
Welcome to Zambia Hospital Oncology Department. We have been in existence for the last 15 years and officially commissioned 7 years ago. We take great pride in our partners, the Uganda Cancer Institute, Oncology for Africa, ISPO, and the Ministry of Health, without whom we would not be in existence. I take pride to introduce to you the team that we work with in Zambia Hospital Oncology Department. We have 2 surgical oncologists, 2 medical oncologists, a gyne oncologist, 2 medical officers, and a host of dedicated nurses in the oncology service. Currently, we offer a wide range of services here in the oncology department. These range from screening to preventive to curative to even palliative care services. We have 2 dedicated medical officers. We run a breast clinic on every day of the week. We run a surgical oncology clinic on every day of the week. We run a medical oncology clinic 2 days in a week, and soon we'll be transitioning to have it run on a daily basis. Once a week, we conduct the gyne oncology clinic, and we are able to give this all to our patients. We have capacity to offer chemotherapy to our patients. We have capacity to do a wide range of cancer-related surgeries that stem from GIT, breast surgeries, uro-oncology, cardiothoracic surgery, neurosurgery, colorectum. So we offer all this, and very, very soon, in the near future, we'll be able to offer radiation services to our clients. I welcome you to Zambia Hospital Oncology Department, where tranquility meets expertise. Please consider choosing Zambia Hospital as your #1 destination for cancer-related care.
My name is Dr. Geoffrey Madeo. I'm a consultant orthopedic surgeon working in the Department of Orthopedics at the Mulago National Referral Hospital. Orthopedics is a discipline in medicine that deals with disorders affecting the bones and joints. It could be deformities due to congenital abnormalities. It could be new problems acquired, like during injury, and it could also be due to diseases that result from degeneration as we age. Okay? Currently, orthopedics is treating a lot of conditions due to trauma. because of the increased road traffic accidents in Uganda. Specifically, this camp today, we are dealing with degenerative diseases that we see mainly occurring in the elderly patients. And this camp is dealing with degenerative disorders of the joints, of the knee joints mainly. So what we are doing today is joint replacement, and we are replacing joints that have been damaged due to wear and tear secondary to age. And today we have done so far about four patients, and the patient that we've just done this afternoon is an elderly lady who missed surgery last year. Remember, the knee camps have been going on every year here since 2015, although there was some interruption during the time of the COVID-19 episode. For 2 years, we couldn't do the camps. But now, this camp that is taking place today is a bigger camp. In the past, we used to have a camp for 1 week, actually 5 days. But this time it has been planned for 10 days, starting from 18th to 28th. So we shall have a patients worked on this week, and then other patients will be worked on next week. So this has been an expanded camp to try to cover the deficiencies that we had in the past because of the limited time that was allocated. So we have patients who are being taken care of today, and there will be some that will be taken care of. Today's patients, in the morning, we had an elderly lady, very heavy. One of the factors that cause a degeneration of joints is being overweight. And many of our ladies tend to be overweight, and they get problems of wear and tear of the joints, and we end up with this kind of problem. Now, the second patient, also, although she's not very heavy, but she had a deformed knee, which in local language, how do you call it? Bariga, knock knees. And so such a deformity also increases the rate of wear and tear. Now, in joint replacement, we take away the damaged cartilage and replace it with an artificial joint, both in the bone of the thigh and the bone of the leg. And that takes away the pain and reduces the need for taking pain medications, which have already been associated with a lot of conditions like kidney damage. I know many patients right now are on dialysis because many Ugandans like taking painkillers over the counter. They don't get prescription, they take a lot of medications. But after doing a knee replacement or a joint replacement, the need for painkillers reduces. So this camp is very useful for our population, and we shall try to cover as many patients as possible. Hopefully, we shall cover the patients that have been missing for the patients.
My name is Dr. Jane Nachibuka. I'm a senior consultant physician and intensivist, and I serve in this general adult intensive care unit at Mulago National Referral Hospital. So in the general intensive care unit, we receive patients who are critically ill and are categorized in the various ways. We have patients who've undergone major surgery and require postoperative high care in the intensive care unit. We also get patients who have injuries such as severe traumatic brain injury, and that's our biggest population. We also receive them in the ICU for neurocritical care support. We also get patients who have acute respiratory failure. When you fail to breathe because of various situations, it could be severe pneumonias, or you might have aspirated while vomiting. We receive them here for advanced respiratory support, where they put them on mechanical ventilation. Then we receive patients who are also in shock, who are hemodynamically unstable and are not able to be reversed on the ward. So they also come here because in the intensive care unit, we use various kinds of drugs to revive the hypotension while we find the cause. We also receive patients who are convulsing non-stop despite utilizing various medications to assist them. We also get those who are asthmatic, who usually recover in outpatients but have now failed to recover and are on their way to even stopping to breathe altogether. So in the intensive care unit, we receive multiple patients who are both surgical and medical cases. And while they are here, there are many things that happen. So there are various modalities for life support. Like we said, you can have machines added to your care, like a mechanical ventilator, or you might have renal failure and you require dialysis in the intensive care unit, which we call continuous renal replacement therapy. Then you might not be able to feed, and we need to feed you with total parenteral nutrition. So the modalities are varied based on the systems that have failed.
I'm Dr. Orotho Nobat, the clinical head, Department of Surgical Services in Mulago Hospital. By training, I'm a consultant orthopedic surgeon. I trained orthopedic surgery, and I was given the mandate to head the unit, the Department of Surgery, and supervise the services in all the surgical units within the Department of Surgery. The Department of Surgery is one of the clinical departments in Mulago National Referral Hospital, which offers mainly surgical services to patients in the hospital. We have two main areas of operation in Lower Mulago, or the new Mulago as it is known, and Upper Mulago, or Old Mulago as it is known. Of course, our main vision is really to be a center of excellence in offering surgical services in Uganda and Africa at large. We are also a center of training, for all the specialties in the surgical disciplines, and also as a training center for Makerere Medical School and a number of other training institutions around Kampala. We also conduct operational research in many areas concerning surgery, and we are called upon by government, for the ministry, for technical advice. We offer that advice to the Ministry of Health. The surgical department is broad. We have 18 clinical units or operational units, and these include the accident and emergency, commonly known as the casualty unit. This is where all the emergency admissions or patients are received following accidents, acute illnesses, and it is a screening area where patients are, and a holding area where patients are kept for 24 hours, offered emergency.
My name is Phyllis Kisa. I'm a pediatric surgeon and pediatric urologist, and I work with Makerere University here in Mulago National Referral Hospital. I'm one of the surgeons in the pediatric surgical unit, where we have about 6 surgeons, and we have 5 trainees training in pediatric surgery. But also we work with anesthesiologists. We have about 4 designated to our team who are specialized for children. They also have 2 other trainees who are part of their training program here within the hospital. So the services that our unit does, we do work on children who are born with congenital anomalies in the chest, including the esophagus, in the lungs, in the diaphragm, which is the muscle that separates the abdomen from the chest. We also operate on any abnormalities that are in the intestines, on the abdominal wall, any problems in the kidney. But that's for the children who are born with problems. Problems also with the genital organs, as well as the urinary tract. And some children may be born without parts of the intestine or the anus working. So we have to operate on those ones, either to temporarily allow them to survive, but mostly also to give them functioning body parts. The other work that we do is cancer surgery. We do cancer surgery, again, for children with cancers, mostly in the abdomen. So it will include the intestines, any organ that's within with the abdomen, the bladder, the tubes for urine, the kidneys. There are different cancers children can get. There are other cancers that children get that grow in the back that we also deal with, and they are all of different severity that we deal with. Sometimes you also have to deal with cancers in other areas, other types of tissues or parts that are within the abdomen. The things that we don't deal with are things to deal with bones, the brain, the heart. Is the things that we do not deal with in our units. We'll operate on the smallest children, even less than 1 kilogram, and some of them are born with problems with feeding, or their intestines have problems, and usually the operation is to reverse whatever that process might be to allow them to survive and feed. And before the operations, we give them fluids and some forms of nutrients, like some protein through the IV as we prepare them for the operation, or until they can feed before that. Some of the other things we also offer is we have an ICU for children. It still needs a lot of work and training for more people to be more keen for children, especially those that have operations. They are good for children with medical problems like pneumonia. Their heart is not working quite right, with the heart failing to work or the kidney failing to work. But when a child has had an operation, we need more people to specialize to deal with a child who has a cut on their body. We also run a clinic. We run 2 clinics, one on Wednesday, which is the main clinic of our unit. We see outpatients coming to our clinic, and we see patients from all over the country. They'll come either referred to us, or they come in as an emergency. Usually it's a very busy clinic, and they see over 50 patients. Before, it was even heavier than that, and it would almost last the entire day. So we split our clinic into 2 and run the other one for patients with urologic problems, that is problems with the urinary system, on a Tuesday. Part of the other thing that we do on our unit is we teach. We teach medical students, usually the ones from Makerere, but there are other universities that also come here. IU, and some other ones that come here with their trainees that also come to our unit for training. We train the future pediatric surgeons through our unit as well. We also train future general surgeons. So most of those are a program through Makerere University. So we train those ones as well in the areas of managing children with surgical problems. The other thing that we do in our course of work is sometimes children get complications, or some may even lose their lives, and we always have meetings to try and understand what is happening with them. These types of meetings usually try to help us find ways to improve our care so that we are always a step ahead on trying to make our patients get the best from what we do.
am Nasa Kakembo, one of the pediatric surgeons in Mulago Hospital. Where we are at the moment is a pediatric surgery unit which works on babies born with congenital abnormalities. In the neonatal section, we have seen one baby who was born with intestines outside his belly, and that's a condition we call gastroschisis. In the second caption, we have seen a similar baby whose intestines were fully reduced back into the abdominal cavity and is on his way home. The pediatric surgery unit handles surgical problems for children from day 0 of life to 18 years of age. And we majorly deal with children who are born with congenital abnormalities. If I'm to mention some of the conditions we handle, gastroschisis, where babies are born with intestines outside. We also deal with children who are born with what we call imperforate anus. These are babies who are born with no provision for going to the toilet. We create that provision for them. We also deal with babies whose intestines get problems like blockage and they present with vomiting. We also operate on babies who develop cancers, especially cancers of the kidneys. These are babies who require operation to remove one of the kidneys which is affected by cancer. We also work on children who are born with the inability to swallow when the esophagus or the food pipe is disconnected. We do the surgery in the first 7 days of life and connect the food pipe for the babies to feed. Those are some of the few surgeries we do here, but the list is extensive. I want to appeal to the general public that this condition is survivable and is treatable. More so if the pregnancy was monitored and this condition was diagnosed before birth, we get a chance to handle and attend to this mother, attend to the baby, and prevent unnecessary death from such a condition.
My name is Dr. Muhumuza Michael Edgar, a senior consultant neurosurgeon, heading the Department of Neurosurgery, Mulago Hospital Complex. Neurosurgery basically handles the brain and spinal cord problems. What we mainly have here are 1, head trauma, especially from accidents, the borders being number 1 culprit. 2, what we call congenital anomalies. These are babies who are born when they are not fully developed. They have defects. 3, infection in the brain and spinal cord. Then we do have the brain and spine tumors. We handle about 5 to 10 operations for head injury patients per day. This is a lot. This is too much. And this has not enabled us to handle the other areas, cases of the other areas I just talked about, especially the brain tumors. Most of these accidents that come in are borders. And I would like to take this opportunity to talk about helmets. Helmets have been found to be very, very protective for head injury, the extent of the head injuries. So it is strongly, strongly advised that if you know that you have to use a motorbike very often, at least invest in a helmet. The border riders, please let them have helmets. This is going to go a long way in helping us reduce on the head injury cases. With all these head injury patients we operate, we are unable to handle the tumors. For instance, as I speak, we have tumors booked as early as 2001, 2022. Of course, you can't leave a patient dying with a head injury, brain moving out, and you're operating somebody walking. These are the challenges we are having. So please, 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 let's use helmets. And the worst and very painful lately is the kids who are being hit by boarders as they move to school early mornings. The boarders, please, let's be disciplined. Thank you.
I'm Seguya Martin, working at Uganda Cancer Institute. I'm a radiation therapy technologist responsible for delivering radiation to the cancer patients. I'm using this is a linear accelerator. It's a true beam. It is one of the best on the market. It is able to treat all cancers. We have different techniques, from the simplest, which is a 2D, 3D. Then we are also able to do advanced techniques like the IMRT, VMAT, stereotactic, radiosurgery, everything. So this machine is able to treat, and it is also able to take images so that we are sure of where we are treating as we planned this patient. It can do an X-ray, like an X-ray. It can do a CT. So all those images are used so that we align the patient exactly as we planned this patient.
Dr. Nabono Godfrey. I'm here at the Uganda Cancer Institute. I'm a urologist. Urologist is the surgeon who is specialized in treating surgical conditions of the urinary tract.
And this operation involves looking into the bladder without cutting the patient. So we call it endoscopic surgery. And in endoscopic surgery, we are using a camera, and this camera helps us to pick the image from inside your body to the screen, the monitor, such that the surgeon is operating using the monitor. On my other hand, I have an equipment which enters to operate the patient. This is called a telescope. This is where the camera is connected, and this end is where it goes to the patient. We connect the light to be able to see inside, and this side we have a wire which is connected to the energy in case we want to operate. So the camera is connected to the telescope, and the equipment is introduced into the patient. As we can see here. So we have introduced the equipment into the bladder. And we just operate looking on the screen. As you can see, we are inside the bladder. This is how a bit of a normal bladder looks, but her bladder is sick. As we are examining the bladder, this is what is called cystoscopy. We are looking inside the bladder. You can see growth. That growth is a cancer. This patient has been on chemotherapy for some time. Chemotherapy are drugs which are used for treatment of cancer, but they remained some cancer which we want to remove by operation. And this type of operation, we don't open up the patient. We just pass through where urine passes, and we go inside the bladder. So what you see there is a cancer
which has blocked the urethra, the tube where urine passes from the bladder to the outside. You see, that is a tumor. We call it a tumor. Any swelling, we call it a tumor. It has blocked the urethra completely. So you can see that is the tumor inside the bladder, and this is the bladder neck. The place where the bladder open is into the urethra. So this is a bladder tumor here, which we can see. That is the tumor. This is the normal bladder lining, but this is the mass. This is the mass which we want to remove endoscopically. Endoscopy means you go through natural orifice. Orifice means an opening. So we went through the opening of the urine system to the outside to access a swelling which is in the bladder inside. Then we will use some energy to cut. Yes? We are going now to test whether our equipment is working. Please step on the diathermy. Today, I was operating on a 65-year-old lady who has been diagnosed with bladder cancer. And she had already undergone previous chemotherapy. So I was doing an operation called a transurethral resection of the bladder tumor. The main aim of this operation was palliative, to allow this patient to pass urine and to reduce the tumor burden in the bladder. She had a tumor which we could not, we got late and we could not give her a curative treatment. That is a radical cystectomy plus urinary diversion, an operation which is done for only those who have a tumor which is confined in the bladder. So she had already undergone chemotherapy, and today we did a TURBT to open her urinary tract because the tumor was blocking her urinary system. The operation took us 1 hour, and by the end of 1 hour, we had removed enough to allow her pass urine. She may require a second operation because we could not resect the whole tumor in 1 hour. With this operation, if you go beyond 1 hour, then your patient will develop complication. So we wanted to be in this window for her in order to avoid complication in an already frail patient. But we are sure at the end of 1 week, we shall be able to remove the catheter on her stomach such that she can be able to pass urine by her own, just like any other normal person. We expect her to be out of the hospital after 2 days.
My name is Dr. Chigundu Spire. I am a gynecologist and I work with Henry Hospital as a minimal access surgeon. I also work as the acting president of the Association of Laparoscopic Surgeons of Uganda, an association that brings together all practicing minimal access surgeons. So today I'm privileged to talk about the scope of minimal access in the country. Minimal access is known world over as the modality we use for most of the surgeries, let it be general surgery, urology, gynecology, neuro, whatever you want to think about, minimal access has place. And as a country, I think we have made very good strides in the right direction, because as I speak now, through the Association of Laparoscopic Surgeons, we have trained over 100 surgeons in the country, and these surgeons are able or have established practice within different hospitals, renowned hospitals in the country. And these are private, profit, private, not-for-profit, and also public institutions. Of course, we still have a challenge that the numbers are still small,
and logistical challenges here and there, the cost of training, but we are working so hard to make sure that we catch up with the developed country so that we can give our patients the best care, the best surgical experience through minimal access. Minimal access generally brings many advantages to the patient. One of them is the fact that patients stay short in hospital. It really minimizes the hospital stay of patients, and this works to free up hospital space and bed space. Generally, compared to open surgery, a patient who has had minimal access can stay an average of 1 or 2 days in hospital. It reduces on the pain, the post-operative pain, reduces on bleeding, it reduces on complications like infections, and it generally gives the patient a very good surgical experience. So this is the reason why we come out as the Association of Laparoscopic Surgeons to help to teach many more surgeons. Our dream is to be able to create awareness to the public, to be able to train more than 50% of our colleagues so that they can embrace this technique in their practice. And for the last 2 years, because the association is still young, it has only been in place for about 2 years. So we hope that in the next 5 or 10 years, we shall have made a lot of ground and mileage in this area. Laparoscopy. Yes. So, to the viewer who is curious about laparoscopy is the form of surgery where we use tiny small punctures on the belly, tiny small punctures of less than 5 centimeters, compared to the traditional, large incisions on the belly. This time we use small punctures, and then we use a camera. We introduce a camera in the abdomen, and this camera is able to see. It has better visibility, it has better magnification. Then we use tiny little instruments to operate. We can do any surgery that there is in the world using this kind of technique. It depends on the surgeon's experience and expertise. But generally, most of the surgeries can be done, especially common ailments that we grapple with. So this is the technology that we call laparoscopy or minimal access. And it is available in the country for those patients who have most of these surgical ailments. They should always talk to their doctors about this option, and I'm sure they can now access it in most of the hospitals. As I said earlier, which kind of patient would require to have minimal access? In my opinion, all patients can benefit from minimal access. Let it be a baby born, a 1-day-old who requires surgery for any sort of reason. Let it be an elderly patient. For the common ailments are things like prostate, removal of appendix, removal of the uterus,
Delegates,
with the ovaries, problem.
Can we get all the delegates back? The minister, the guest of honor is coming in a minute. I don't know where the organizers. Members of the organizing committee, please. Can we bring back people? Members of the organizing committee, can you guide the people back in the meeting? Because I left the guest of honor on the last 2 stalls. Can we stand up, please, to receive the guest of honor? And members, please come back to the hall. We are starting now. Honorable Minister. Honorable Dr. Ayume. Honorable Minister of Trade and Industry, Honorable Francis Mwevesa, who is representing His Excellency the President. You are very much welcome. I request that you allow us to take the anthems and a prayer in order to start officially. Ladies and gentlemen, let's stand up for the national anthems. And sir, I request that we do one stanza, if you allow, of each. National anthem and East African anthem. The people not ready? Will we manage this? Before we sit, may I request that we have a prayer, and I invite Professor Moses Galukande to lead us in a prayer. Professor, are you around? Okay. Quick volunteer.
I'm not Professor Galukande, I'm Dr. Kanyesige. Let's pray. Our loving Father, we thank you for this wonderful gathering. We thank you for the gift of life. We thank you for the gift of healing. We commit this meeting into your hands, and we pray that it blesses you and blesses your people. We pray this in the precious name of your Son, Jesus Christ. Amen.
Thank you very much, Dr. Kanyesige. May I request that we take our seats. Guest of honor, Honorable Minister of Trade and Industry, Honorable Francis Mwevesa, Honorable Minister of Health, Chairperson Parliamentary Committee. I saw that. President, please. Sorry, your seat is here. the Permanent Secretary, Ministry of Health, honorable members of Parliament, the President of the Association of Surgeons, the steps at the other side, all colleagues from the medical fraternity, invited guests, ladies and gentlemen. Guest of honor, thank you very much for joining us, and thank you very much for accepting to officiate on this landscape exhibition by the Association of Surgeons of Uganda, and to represent His Excellency the President. Furthermore, we thank you very much for being available to participate and support the health programs, especially like you had cabinet today, but you had to commit time to be here. This year's conference has 3 components: a scientific conference, which we are having, a surgical camp, and a landscape exhibition, which we have just covered. So my role is a simple one, just to moderate the function today and to invite the key speakers to give their remarks. And today we are not having very many, we are only having 5 speeches. We'll have a speech from the President of the Association of Surgeons. That will be followed by a speech by the PS Minister of Health. Then we shall have a speech from the Chairperson, Health Committee of Parliament. And then we shall invite the Minister of Health to invite you guest of honor. But guest of honor, just as I conclude, allow me to inform you that we have very many stakeholders in this conference. We have delegates, we've been having delegates from Parliament. Some of them have just left, but we had representatives from the Health Committee, and they were here with us. We have colleagues from Ministry of Minerals and Energy. We have colleagues from Ministry of Internal Affairs. We have colleagues from Office of the Auditor General. We have colleagues from Regional Referral Hospital. We also have the President of Uganda Medical Association. We have the press. We have civil society organization. I think there's SEHAD. I saw Walimu here and others. We have members of the academia, and of course, members of the medical fraternity. We have senior members from Ministry of Health and surgeons who are our main hosts today. So with those remarks, guest of honor, allow me to invite our host, really, the President of the Association of Surgeons, to give his remarks, and maybe he will also introduce some people who are key, have been key in the organization of this meeting. That is Professor Frank Asimwe, who is a professor of urology at Makerere University, but also working in Mulago Hospital.
Thank you very much, the Director General, whom I have worked with for many years as a young man. The guest of honor, Honorable Minister, our members of Parliament, Permanent Secretary, Minister of Health, directors and commissioners from the Ministry of Health, our beloved President of the College of Surgeons of East, Central, and Southern Africa, Dr. Fwalal, the President of Uganda Medical Association, Dr. Herbert Luswata, President-elect of the Association of Surgeons of Uganda, Professor Moses Galkande, our elders in the profession, Dr. Kanyesije, and many others who have graced us, Dr. Kiria Mzei Wakazi, our senior surgeons, Dr. Nadumba, Dr. Mabwijano, fellow surgeons, young and old, exhibitors, ladies and gentlemen. The Association of Surgeons of Uganda welcomes you to the second edition of the Asou Surgical Landscape Exhibition 2024. We are extremely honored by your presence, and we don't take it for granted. The proverbial party which was thrown and no one showed up has not happened to us. At least you have come, seen what we have exhibited, eaten our food, and shared in our joy. Asou has been in existence since 1987 and seeks to keep the flag of the surgeon as an individual, as a professional, like has been said about one of us, and also the flag of surgery as a profession, as a trade, as a practice, flying high in Uganda. We are concerned about issues of professionalism, training, and sometimes the training can be an apprenticeship, which leads to skills acquisition. We are custodians of the science of surgery, research, and collaborations. As has been mentioned, Asou carries out surgical camps in the country, in the regions 12 to 14 of Uganda. And in this, we seek to take quality services, surgical services, to the people who would have otherwise not benefited, either because of distance, or because of money, or because of both, often because of both. The Surgical Landscape Exhibition is a brainchild of Asou and seeks to showcase the breadth, the depth, the variety, and complexity of surgery in Uganda. This year, the Ministry of Health sponsored and worked with Asou to elevate this exhibition to a national stage, and we are extremely grateful. I ask my colleagues to please clap your hands for the Ministry of Health. The Ministers of Health, the Permanent Secretary, the Undersecretary, the Directors, Commissioners, and all the staff literally opened their doors, laid down their expertise, and availed it to Asou to help us execute this exhibition at the Kololo Independence Ceremonial Ground, a thing we had never dreamed of, but we have achieved, and we are very grateful. This has enabled us to have more exhibitors, more visitors, although there is still some work to do. We could do better. Including you, the guest of honor who has graced this occasion. We have come to the national stage. Our performance still has a lot of improvement, but we have arrived at the stage where we should be performing as surgeons. So we thank the Ministry of Health for throwing their weight behind this good idea. This is a sign of clear-headed leadership, and we want to thank them once again. When a small group like us come up with an idea and the ministry opens their door, throws their resources, including money, we are most honored. Honorable guest of honor, with the visionary leadership of His Excellency, intentional investment in the health sector over the decades has enabled the profession of surgery to grow into over 25 subspecialties. Very many. I have got a list, you can peruse through it. Uganda can now proudly boast of performing transplant surgery, separation of conjoined twins, complex open heart procedures, laparoscopic abdominal surgeries, other minimally invasive procedures in neurosurgery, urology, ear, nose, and throat, including cochlear implant. All these things are happening in Uganda. Orthopedic surgery, all the subspecialties listed below exist in Uganda as we speak. And they perform surgery to the highest level of skill and are represented in the current exhibition as you have seen. After visiting the stalls, I'm certain, and of course listening to the presentations made here, that honorable guest of honor and distinguished delegates, you can now attest to the expanding landscape of surgery in Uganda today. We are steadily taking away the need to refer patients abroad. And I don't want to be the one overemphasizing this, but we are steadily taking away the need to refer patients abroad and turning the tide to attract patients from beyond our borders so they can come and seek surgery here in Uganda. We can clap. In this, I'll just add, personally, my opinion of medical tourism is that medical tourism should be encouraged. Just make sure you cook a better meal. Then the tourists will be attracted to you. Then maybe a Ugandan who wants to tour elsewhere can go just for reasons of tourism, but not because of lack of services. I will not read the 28 subspecialties, but they are attached, some of them with very long names: otolaryngology, oromaxillofacial, hepatopancreaticobiliary surgery, and so on and so forth. These are not just on paper. They are not just out there. They are here with us, established, doing work routinely, represented by Ugandan staff, and growing strong, honorable guest of honor. Asou would like to appreciate the government of Uganda and His Excellency the President for the robust revamp of education in the country at all levels that has lifted the literacy rate of Ugandans to the current rate of 80.6% as of 2022, coming up from 50.6 in 1991. A literate population by default improves their health-seeking behavior and therefore turns into a healthier population. I used to do VVF surgery, and the belief in one of the tribes was a mother who goes to deliver in hospital is a weak mother. And because of that, they would suffer obstructed labor until they get torn and get fistulas because they don't want to appear weak. Now, as the population gets literate, even by obtaining a P7 graduation, if it can, you can call it that, I think we can call it that, that alone improves your health-seeking behavior, and we want to thank His Excellency and the government and the Minister of Health for this effort in the education sector. Medical training at bachelor's level, graduate level, specialized level has also improved commensurately. And as such, some, and I've used the word some deliberately, of these educated Ugandans are able to meet some specialists that are trained to meet their expectations. One of the subspecialties we have is bariatric surgery. If you are struggling with weight and you want your stomach to be reduced, you can get those services in Uganda. These are tremendous strides, but require improvement, as we'll be suggesting below. In the same spirit, guest of honor, Asou would also like to appreciate His Excellency and the government of Uganda for setting up specialized surgical services in the country at national level in Mulago Specialized Hospital. I know it is in the labor ward, it's about to be birthed. Mulago National Women's and Neonatal Hospital, Kawempe, Chirudu, and some at regional referrals, at regional level, like the Entebbe Hospital, which was here, the Uganda Cancer Institute, which has opened branches in Lira and Mbarara, and also in collaboration with the private entities, Cure Hospital in Mbale, which has been mentioned, and Chabirwa, not to mention the PNFPs. There has been a deliberate effort by government to establish these specialized hospitals, and that's a great stride for us who provide specialized services. Asou would finally like to appreciate Your Excellency, His Excellency the President and the government of Uganda for creating a conducive environment that has attracted private investors to set up hospitals, especially in Kampala. Of course, the capital city takes the lion's share. That employ specialists to provide this specialized surgical care. We are training specialists and super specialists. It would be sad if these specialists came back and there was nowhere for them to practice. As testified by the neurosurgical group, the super specialized neurosurgeons are now remaining in Uganda because they can practice their skill. This is an effort of government to set up specialized hospitals, but also to provide a conducive investment environment for private players to also set up these hospitals. I've only mentioned a few: Nakasero Hospital, IHK, Eurocare, Kampala Hospital, KES, DHS, Rubies, to mention but a few. These hospitals have invested in technologies, in diagnostics, and intervention. For you, the specialists, when we are talking about technologies, you know what that means. When you want a CT scan, you don't want kwara. When you want even a simple ultrasound scan, it matters who has done it and what machine they have used. So these hospitals have invested in technologies, diagnostics, and intervention technologies. For instance, some hospitals are able to do embolizations. You know, they can do fibroid embolizations. Some of these hospitals have got laser machines. Some of these hospitals, I can go on and on, cath labs. When you're talking from the paradigm of the specialist, you need these kinds of technologies. And so we don't take it for granted that government has created an enabling environment for these investments to be made. So for that, we appreciate these investors and government and hope for more. Finally, Asou has got a few asks. We've got a few requests. One, that increased funding for specialized training in emerging specialized areas for transplant surgery. Of course, I'm being a bit selfish here, I must confess. Minimal invasive surgeries in all subspecialties: GI, gynecology, urology, ENT, neurosurgery, including robotics. And I'm glad the PS made an announcement on that, but we need more of this deliberate investment in this training, because that's where we have reached, and in fact, that's where we had lagged behind in the East African region and in the African region. Two, increased funding and investment in technologies for diagnostics, intervention, and critical care. Those levels, the technology will make it or break it. We need deliberate investment, CT scans, MRIs, Doppler machines, ICU equipment, because you can do a very successful surgery. Dr. Sekabaya was telling us the separation of the conjoined twins took 24 hours. If there was no ICU, there is no way those conjoined twins would have survived. And this specialized care requires technologies, and there must be intentional investment. Let me just spend a little more time. Sometimes, especially the businessmen, want to put the cart before the horse. How much money is going to come out of this? When will my money come back? Let government lead the way, and the private investors will follow. Three, we need proactive recruitment, deployment, and retention strategies for surgeons in the national healthcare systems. We need surgeons up to district level. And if need be, this surgeon can make rounds in the health center for. Maybe every 3 months, the surgeon on the district hospital can go to the health center for, and then moving upwards, the regional referrals, and so on and so forth. There must be deliberate effort, and I know it's going to take place. Increased funding of the national health budget from the current 8.9% to at least 12%. Don't ask me the magic about 12%. I just threw it there. Just add a 3%. One sure way of closing this funding gap is by setting up the National Health Insurance Scheme. And I know that has been talked about, but we want to lend our voice to this, that this needs to happen. A healthy population is a productive and wealthy population. So as we go on about Bonabagagawale Operation Wealth Creation, health is paramount. I know I'm speaking the converted, but I must say it. Finally, the Association of Surgeons of Uganda has set up a circle for individual surgeons' financial development. We are requesting for a small contribution of just 1 billion Ugandan shillings, so that we can also get some money. And we can achieve some bit of personal financial liberation. Finally, very finally, but very importantly, I would like to appreciate in person the members of the Asou Executive Council with whom I've served. Honorable Guest of Honor, we have served for 2 years. My term with my council is coming to an end come Thursday, and I would like to call out the following persons to at least stand up for recognition, with whom I've served for 2 years. They are the ones who have churned all these ideas that have popped in these 2 years. They are the ones who have been behind the scenes. They are those who operate silently, but they deliver. They are those who splash things in our faces. But at the end of the day, we've worked like a well-oiled machine to deliver the bit that we have managed to deliver. Professor Moses Garukande is our president-elect. I would like to recognize him. Thank you very much. Sometimes I think I was keeping the seat for you. I hope I've kept it warm enough for you, sir. So he'll be taking over from me come Thursday. But we have also had the General Secretary, Dr. Edward Kakunguru Prince. Thank you very much. Without spilling any beans, this surgical landscape exhibition had something to do with him, quite a lot. So thank you very much, Dr. Kakunguru. Another round of applause. Dr. Michael Eden Setabi, our treasurer, he looks the money. Owechitiwa musajja wa Ssaabasajja. Thank you very much. Dr. Victor Chigonya, our publicity secretary. Thank you very much. Dr. Flavia Were, our assistant secretary general. She's somewhere moving mountains. When she comes, she will wave. Dr. Anne Shikandwa, information and library secretary. She may not be around. Dr. Christine Namugenyi. I don't have words to describe you, madam. Thank you so much. We have regional representatives. Dr. Emmanuel Boa, Eastern Region. Dr. Ronald Okidi, Northern Uganda. Dr. Dennis Bitamazire, Western Uganda. Dr. Nasa Kakembo, Central. This man has served the council for maybe 12 years and is still growing strong. Dr. Timothy Makumbi, Mulago Hospital. Dr. Hussein Senyonjo, the immediate past president. Dr. John Sekabila, past president. Thank you. Dr. Josephat Jombwe, COSEXA representative. And Dr. Joel Chirawire, COSEXA country representative. I thank you, guest of honor, Ad Majora Tendimis.
Thank you very much, Frank. I think the message was very clear. I don't have to repeat anything or summarize anything. But in the interest of time, allow me, guest of honor and Honorable Minister of Health, to invite the PS Minister of Health to come and make her remarks. PS of Health, Dr. Diana Otwina, I think doesn't need her introduction.
Our guest of honor, Honorable Minister of Trade, Honorable Minister of Health, the Chair of Health Parliamentary Committee, the President and all the past presidents, our Director General and all our distinguished guests today, thank you so much for coming. Guest of honor and Honorable Minister, we want to thank you for honoring our invitation and being here with us. And we had a great discussion this morning We had many panels that really were able to share a little bit more on what they are doing. And when we listen to these doctors presenting, it became very clear that over time we have built really expertise in the country. But what is very clear that the public and the people out there may not actually know what we are able to do and the skills that we have developed over time. And we also noted that there is urgent need to have the council, the organ transplant council, established. And we promised the team that we have worked on the budget, which tomorrow, a good thing the chair is here of the health committee. And so we are going to make our submission to see whether we can get some resources, and we prioritize so that the council is able to be put in place and we are able to start without any hindrance. The other thing Honorable Minister wanted to report is that Rubaga is also ready, as they explained, and they want to start liver transplant. And they were just hindered by the procedural aspects. And we do believe that if we work with them quickly, they will be able also to start. As I conclude, I want first of all to congratulate the doctors for the milestone that we have attained. We want to thank you for the commitment to your country. You could have gone elsewhere. There are many green pastures and many temptations to take you away from your country, but you chose to stay, even with so many gaps. So many gaps in our service delivery, but you have chosen to stay and you have worked. You have used what is at your hand to deliver services. You have saved millions of people. So many people have come when they are in dire state of almost dying, and you have been able to give them the hope. So we really want to thank you so much. And on behalf of Ministry of Health, we commit to work with you to ensure that the small beginnings that we are seeing, the advancements that have started, the opportunities that have opened will continue to grow. We shall nurture those beginnings with you. And we do believe that you will get there. You can count on us. We may not be able to provide everything that you may need. But we want to call upon the people that are in the responsibility of providing resources and appropriating resources to focus on tertiary care of this country. The landscape of diseases that are now coming on board, the non-communicable diseases, the increase in life expectancy, the geriatric complications that come along with old age, the cancers that we are seeing that is increasing, and cardiovascular diseases. We need to empower, we need to prioritize, and we need to focus our resources. I know that we don't have enough resources, but we need to focus enough resources so that we are able to put the basic. In 2024, our National Referral Hospital, without laser machine, the basic advanced machine. Yet we know that for surely we have not failed to get money. But it is how we, I think we divide this money. So for us in Ministry of Health, we are saying we are with you. We are with you in this struggle. We are going to work with you. Our doors remain open. We shall continue knocking at the doors of those that appropriate money and also provide money to make a case. And for us, Honorable Minister, I think it will be our legacy that if we set our targets as the sector in the next 3 to 5 years, and we come out clearly, there are very, very clear things that we want to see in our sector as far as tertiary care is concerned. And we just splash to anyone who wants to listen to us. And we splash it together. We want to see the doctors. We want to join a force with you, that we will raise this voice. We raise this voice together in Parliament, in Finance, in Cabinet, so that we are able to get the attention that we need. Thank you very much. I want to congratulate the association, our president, the outgoing and incoming. We want to thank you so much for the milestones that you have attained. And we are proud to associate with you. And we know that if we continue to work together, it is very possible. Where there is a will, there is always a way. And I want to thank also COSEXA for the training. The work that you have done is amazing. The specialists basket we are seeing increasing every day. It is your hard work. Thank you so, so much. And we do believe that in the next possibly 10 years, we really have a big workforce that we can reckon with. Thank you so much, and allow me at this time to invite the chair of the committee to make a few remarks. Thank you.
Our dear guest of honor, the Minister of Trade and Industry, Honorable Francis Mwebesa, our dear Minister of Health, Dr. Jane Ruth Acheng, our Permanent Secretary, the Director General of Health Services, Dr. Mwebesa, the President of Asou, and the President-elect, distinguished ladies and gentlemen. It's an honor once again to be here. I am speaking for the second time, honorable guest of honor. And a lot of issues have been deliberated upon today. And without repeating myself, I want to say, my colleagues in the profession, I know sometimes it's very frustrating. From your side, the way you look at it, I was once that side, and I think I used to blame our honorable minister. I used to blame members of parliament, but now I'm on this side, and I take it a bit slow to throw stones because I'm now in the glass house, and it's not easy. But we have not forgotten you. We try our best. You know, I didn't think I would come to parliament, and sometimes I'm on a table at home looking at a report, moving figures and things like that to ensure that the following day in the afternoon I'm able to convince Parliament. We have walked this road for the last 3 years with the Minister and her team at the Ministry of Health, trying to ensure that we speak to the strategic plan of the ministry, of the sector, and to the aspirations, what we have set out to achieve. Every year, there are some gains and there are some losses, but we live to fight in the next budgeting cycle. And not hope has all been lost, Mr. Guest of Honor. I would want to start by thanking His Excellency, the President, and please thank him for us that he has addressed one of the most important issues, and that was human resources for health in terms of salary enhancement. Whatever we are trying to do in terms of infrastructure, equipment, would not make meaning if the people seated behind them are not motivated. Even with advancement in artificial intelligence and robotics, you will never run an OPD or a ward or a hospital with robotics. But you can run a military with them, with drones, and they'll go thousands of miles, bomb, and come back. But the health sector, unfortunately, is not like that. Even with the laparoscopic surgery, you still have to have somebody to man those tools, to man those gadgets. So His Excellency, Parliament, and the Ministry addressed the most fundamental issue, which was human resources for health. And I really want to salute him in that direction. And of course, the health sector has many facets. You're dealing with anesthesia, obstetricians are complaining you've forgotten us. There's issues to do with blood bank, regionalization, collection of blood. There is cancer, there's cardiovascular. So for us from this side, we have to move as a team. You cannot champion surgery or obs-gyn, and you're forgetting blood banks. You're forgetting vehicles for blood, and so forth, capacity building, training. And so much as the 3 trillion looks very glossy and you're wondering where is the ministry putting this money, it is moving different aspects of the health sector. We're also looking at primary health care and so forth. So I would like to end by saying I would really want to juxtapose this same tent, the way it is, Honorable Minister, with your permission, to the grounds of Parliament sometime this year or next financial year, so that our fellow colleagues are able to walk through. I'm sure the guest of honor was mesmerized today. And so that our colleagues in Parliament are able to walk through and see what Ugandan doctors are able to do and what they are doing currently. So we shall have to bring this to the attention of the leadership of Parliament. The timing is, you'll let us know. We shall also let you know when Parliament has the time and when you have the time, so that this exhibition is also done in Parliament. I know when we talk about exhibition now, it's a very wrong, but I'm saying this whole thing is put up in Parliament and we can walk through. Bubu is not only in commodities, it's not only in goods, but it's in services. So it is buy Uganda services and build Uganda services and buy Uganda services. On my side, as chairperson of Health Committee, I pledge to keep on working in the interest of the profession, but also most importantly, the people of Uganda. I thank you very much, and please allow me to now invite our dear Minister of Health to make a speech. Thank you.
Our chief guest, the Minister of Trade and Industry, Honorable Francis Mwebesa, the Chair, Health Committee of Parliament, the Permanent Secretary, Ministry of Health, the President of the Association of Surgeons of Uganda, the Director General, and all your technical teams present. The President-elect of the Association of Surgeons. Now there are very many presidents. President, College of Surgeons of East, Central, and Southern Africa. President, Medical Association. President, Association of Surgeons of Uganda. But remember, His Excellency said these are all small presidents. Elders in the profession, the media, ladies and gentlemen. Allow me to start by congratulating the Association of Surgeons of Uganda on this second edition of the Surgical Landscape Exhibition, and to thank you very much for the initiative. It is one of the ways that you are opening the eyes of Ugandans to what we can do here in Uganda, and also to make them understand how far we have come. In a special way, allow me also to appreciate you for the good work that you are doing for the country, the lives you have saved, and also the services that you have extended to now 16 regions, Mr. President. They are not 14, they are 16. They will soon be 18. So we are still counting, just like we are counting districts in Uganda. We are counting regions. But once we reach 18, we shall stop. I don't want to scare you, but thank you very much. The Association of Surgeons of Uganda, in a special way, has taken their profession far. And I want to encourage the other associations to do the same, to move around the country. The work that you do, and I can testify to the impact that you left in Lango. People are still singing about the association. Every time I step in Lango, I'm asked, when are they coming back? But I always tell them I prefer not to answer that question because the 16 regions are very many and the resources are limited. Our chief guest, I had many things to say, but specifically I will say 4 things. And these 4 things I request that you take them to His Excellency the President, since you're representing him. I will support you when you're saying them. Number 1 is health is expensive. I have moved to many places in this world. I have never found where services in health are given free of charge, except in Uganda. We are hiding our heads in the sand and pretending that services can be free. What you have seen today in the exhibition is extremely expensive in terms of equipment, in terms of human resources, in terms of time, in terms of the consumables used, and the post-operative care. Extremely expensive. And you were in one of the booths where you were told about intensive care and how much it could cost, and the fact that very few can afford. Now, because it is expensive and we don't have money, and you are very much aware that the National Health Insurance Scheme Bill has been on the agenda since last year, it needs to be fast-tracked, because it is the only way we shall mobilize additional resources for health. We cannot keep on talking about free health services. Somebody must pay for it. And in this case, the reason why we cannot do so many is because we don't have the money. But there are so many people out there who need these services, and we need to give it to them. So we need money. Number 2, we need to invest more You had the PS making a commitment for the Ministry of Health to invest more. Unfortunately, we may not have the money, so the investments may be in small, small baby steps. Now, to invest more, we need to prioritize and we need more money. So that still goes to tell you that you need to tell the president, and this time you say, Jane, come and sit here and we talk. We need money. We don't need money on paper, we need money in cash to improve the health services in the country, to make people more healthy and more productive, because that has been, I think it has been our vision for so many years. And one of the secrets is when you make a population healthy and productive, they will never bother you politically. They will turn their eyes the other side, do your politics. People are healthy, why should they bother you? Number 3 is we need to train more specialists and recruit them. I am happy that we have revised the structures and expanded the structures. We now need to take deliberate steps to recruit and retain people. And of course, pay them better. We are already paying, but we are not yet there. You heard with your own ears the challenges. The specialists want to undertake corneal transplant. The specialists are too few. Recently, with deep appreciation, we had a renal transplant done. Even then, the specialists were too few. When I was answering questions before the media, it was hard to say there are 1 or 2 or 3, you know, and many others that these people want to do. So we need to invest in training, and we have been making appeals to the president that even if we only train 5 per year, 5 per year, and add on to what we are doing, 5 every year, within 5 years we've trained, 10 years, we'll have trained 50, and it is not a small number. There are some specialties we cannot train here in the country, and we need to take them out. Lastly, this one is to the Association of Surgeons and to all of you. We need to tell people what we are doing. We need to publicize. We need to shout. We need to go to the mountain tops. I know we all inherited this behavior from the British. By the way, they left us there, they taught us, and they left us there. The reason why is because they did not want you to advance. Colonial spirit. When you go to London today or Great Britain, they are advertising all their services. Why? Why should we keep quiet? You separated those conjoined twins for 24 hours, and you went home very contented and happy. And some of us in the ministry are getting to know about it today when they are 2 years old. Very painful. There are many other heroic surgeries you have done. You keep quiet. Can we please wake up, lay down the colonial spirit, and start talking? Advertise on the walls of Mulago. How many of you have gone to India for whatever, whether it is training, you know, surgery or whatever? Immediately you step into a hospital, you see the adverts. We are able to do this, we are doing this, you see the TV screens running. It's not there in Mulago. You are quiet, you are hidden in your various subspecialties. The regional referrals, can you advertise? Tell us. Let the people know what you are doing. Please, let's make documentaries. Let us shout. Let that spirit, I want it broken today. And you come out of yourselves. How will my grandmother in the village know that you do open heart surgery? When she gets a cardiac problem, she will start, when will you take me to India? You can do it here. When will those people in Kisenyi know that you can do those surgeries? When? even amongst ourselves here in the various hospitals, people don't know what you do, because most of the specialties are concentrated in Kampala. The regions don't know. I know it is expensive, but we are here to support you, to spread the good news. So with those remarks, once again, allow me to say a big thank you. You make us very, very proud. We are really proud of you. And keep on the good work. It is now my honor and pleasure to invite our chief guest, Honorable Francis Mwebesa, who is representing His Excellency the President, to come and deliver the President's speech. Honorable, you're welcome.
Honorable Minister, Honorable Member of Parliament, Chair of the Health Committee, Directors and Commissioners, Executive Directors, Chief Executive Officers of private and public and private entities, the President of College of Surgeons of East and Central and Southern Africa, the President of Uganda Medical Association, the President-elect Association of Surgeons and Surgeons of Uganda, elders of the profession, and all surgeons and exhibitors, ladies and gentlemen, and members of the press. This morning, I was informed to represent His Excellency the President. I think there must have been some reason, because when you are of some age, of some kind, you have gone through all these rituals that I might have seen this morning. And maybe my colleague there, I left her behind, but I was expecting her to come, but eventually she came. However, I'm here to represent the President, and I want to add on your voice about what these people are demanding. Health is expensive, but you can be rest assured, Honorable Minister, you know we sit side by side, and be rest assured that I have had this opportunity. I will definitely support you as I go and talk to the President who has sent me here. You talked about health is expensive. Definitely, government must spend more money on health. You talked about, training, investing in training, investing in equipment, because of what I see here needs money. Otherwise, if money was availed by the government, you can be rest assured I will support you here. However, as I said, I was told to come and represent the President. I could not help saying a few words myself that regards my office and also my office as a parliamentarian. I was talking with her and I said, you are chairman of the committee. Is agreeable with the minister. But some of us, our chairman of the committee, it is always, honorable member, it is always a different thing altogether. I'm just taking on a short chance, Honorable Jane and Honorable Member of Parliament. I wish all chairman of the Committee of Parliament will like you. Not to waste any more time, my job was to deliver a message from the President of the Republic of Uganda, and let me set on my job. His Excellency the President Yoweri Kaguta Museveni, President of the Republic of Uganda, at the second Association of Surgeons of Uganda Landscape Exhibition, Kololo Ceremonial Grounds, 26 March 2024. It goes. I'm happy to join the surgeons of Uganda and other medical professionals gathered here today for the Surgical Landscape Exhibition. This exhibition is a landmark achievement because it has helped showcase the advancement of Uganda's surgery services. I want to thank the Minister of Health and the Association of Surgeons for organizing this event, which is aimed at creating awareness on Uganda's surgical care capacity. Medical care is one of the fundamental human needs, alongside the important needs like food, shelter, clothes, education, etc. This is because it guarantees the quality and longevity of life. When you have poor health conditions, the life expectancy is low. Good health services enable the population to attain a high life expectancy. Therefore, the NRM government prioritizes the health of all people as a strategy for creating a productive and robust workforce, capable of contributing to the socio-economic transformation of Uganda. The NRM considers a healthy and educated population as a precondition of building a rich and prosperous nation. The public health strategy of the NRM government is based on disease prevention, i.e., fewer people falling sick by adopting healthy lifestyles. Once the public is aware of the possible sources and causes of diseases, it is easy to reduce the diseases burden on our healthcare system. Everyone must become their own health care system. Everyone must become their own doctor and nurse in order to succeed in the fight against the diseases. This prevention strategy has helped us to fight deadly diseases like HIV, AIDS, Ebola, coronavirus, etc. Ugandans are more conscious of the health benefits of good health, of good hygiene, like drinking clean and boiled water, proper waste disposal, eating fully cooked food, sleeping under mosquito net, clearing bushes around the homesteads, etc., etc. Government will continue to invest in improving the health infrastructure across the country in order to guarantee access to affordable and timely health care for all. The better economic conditions in Uganda today have resulted in the creation of a middle class that has demand for quality health services. However, it is unfortunate that many of Uganda's rich people have been traveling to India, USA, Europe, etc., to get advanced treatment. Medical tourism will soon become history because Uganda has now made significant strides in specialized surgery and treatment. I am happy to note the medical procedures like kidney transplants, bone marrow transplants, neurosurgery, etc., can be performed in Uganda. This landscape exhibition is one of the ways of raising public awareness about the availability of surgical services in the country. It will help to reduce forex flows of dollars to other countries. Government will continue to provide a conducive environment for training and retaining specialists. The practice of medicine and surgery in Africa has improved over years. Before the British introduced modern medical practice in Uganda, our people were performing cesarean sections. A British traveler, R.W. Franklin, witnessed a cesarean section in one part of Uganda. The first Ugandan surgeon was Professor Sebastian K. Charwazi in 1961. He was also the first surgeon in East Africa. Today, we have close to 400 surgeons trained in the country. This is a clear sign of progress, both in training and service delivery in the country. I am happy to note that there are over 700 Ugandan doctors specializing in different fields of medicine, with 237 in surgical disciplines, specifically in 4 public universities of Makerere, Mbarara, Busitema, Kabare. Their expertise and specialized services will help to boost health sector in Uganda. Finally, I once again wish to thank all surgeons of Uganda and the entire medical profession for your commitment to the patriotic duty of saving lives. I thank you, and I wish you a successful exhibition.
Another very big hand clap for the chief guest. Thank you very much, sir. Chief guest, thank you very much for representing His Excellency the President very effectively. The message has been received and very clearly. Another big clap as we stand up for the anthems. Can we have the anthems in a reverse order, please? you. We shall have a closing prayer by the President-elect. And I'm told we have a group photo. I think the photographers will guide us where to go.
Let's pray. Dear Lord, we are grateful for life. We thank you for this day. It's been a wonderful day, a day to show what you've enabled us to do. We thank you for the population we serve. We pray that they will be able to access these services for the betterment of their lives and to your glory. We thank you for our guests of honor, and everyone else who's come, for their sacrifice, commitment, and passion to the betterment of other human beings. And for the rest of the day, we pray for your grace and protection as we all travel back to our places of abode. In your name we've prayed. Amen.
Guest of honor, we request that you participate in the photograph. So where are we taking the photos from? Here. Okay. So they come down or up? Huh? Okay. Can you help us to put chairs here? So the guests stay up or they sit on the chairs? The chief guest has to sit. The chief guest has to come down and sit, yes. Okay.